Can we now finally close the pressure books and just get over the pressure discussion?
We're all in agreement, I think. Mike agrees, high pressure. The backup rate is maybe still open for discussion.
It's nice to have, I would say. No, I absolutely agree. I think increasing pressure levels is an easy way to take down CO2. We have the evidence that by using higher pressure levels, we are doing good. And for example, we have done another study investigating high-intensity NIV versus low-pressure NIV without changing the breathing frequency, and we have seen the same results. We have seen that we can take down CO2 without changing breathing frequency by only having a difference in pressure level. So I totally believe, and I'm with you, that pressure is the most important thing. We think about, by using higher breathing frequencies, that we give some kind of a muscle rest for our patients, but this is only, well, some kind of a gut feeling. It's not evidence, it's eminence.
So I don't really think we want to confuse the situation. The situation here is we need to drive down CO2. So in our study, IPAP of 24 centimetres of water, EPAP of 4 centimetres of water, with a backup rate of 14, did that. In Thomas's study, it was not much different. 22 over 6 with a backup rate of 16. I think it's time for us to put it to bed because it's boring. And it really drove this field on, which is great, but now we can say there is more than one way to skin a cat. We don't want people to be on very, very high pressures. And who knows, one day, as I was discussing in the symposium, we may be driven towards physiologically targeted low pressure ventilation. And those areas, I think, is where we should see the next set of studies coming through, because that will no doubt increase adherence.
Let me ask a quick one, though, on that. If you knew how to set the EPAP to get rid of the expiratory flow limitation, do you think you'd still need high pressure support?
Yeah, because we've never discussed it before, David. So, so just for those, using some of the technologies we've got available, we can now abolish expiratory flow limitation. We can use EPAP, PEEP, to get rid of expiratory flow limitation. And we can drop neural respiratory drive. We can drop diaphragm pressures. And by doing that, we're going to put people on a better part of the pressure volume curve. And then the hypothesis will be, we'll drop the pressure support, we'll drop the IPAP, we'll drop the driving pressure. The mask won't be so tight. God forbid we'd have people without nasal pressure sores.
I see a difference between what we live in routine. We ventilate a lot of patients with COPD. In France, it's the national database shows that it's the most the preferred indication in France. And we see that in your studies, you spend 10 years, 5 years in HOT to include all the patients. It means, and with a lot of centers, it means 1 or 2 patients per center per year. How do you explain this difference? Do you think that it's because we ventilate too many patients in routine, or do you think that there is a group of patients that should be ventilated and we must still find them?
I think this is a fair comment, and we have discussed this a lot in the past. We needed 10 years in Germany to recruit it, to finish the trial. And I think you have to think about where we came from. In the former days, when we were talking about NIV and COPD, everybody was telling us, well, it doesn't work, and if it works, it's not COPD, it's obesity hyperventilation syndrome. Sure. So the clinical trials comparing to what we are doing in clinical practice is completely different. For example, we are not including patients with a BMI higher than 30. We are excluding everybody with a pH of 7.34, for example, and so on. So it took us quite a long time, but I'm with you that we specifically have to make a cut between clinical practice and studies, and we now have the evidence, and I think we can go further, having other studies including much more patients.
The bizarre thing across Europe, we've been doing the health service research for years. We believed this was an effective treatment. The trouble was, and we've sat in a number of meetings with our North American friends, and it was like we were committing the worst crime in the world. And so I think this is really important to make people understand that what all those Europeans were doing wasn't completely mad, and in fact it was something that was driven by a particular cause, and that was to improve the outcome for patients where we have very little treatment. So I think it's really important we put it into the context of 10 years ago sitting in a room and there was a huge divide across the Atlantic about the whole use of home mechanical ventilation in NIV.
Phenotyping COPD patient who benefits most, it's really a problem. And I am surprised in such studies why we never have information about the CT scan pattern. I'm sure in your patients, Nick, that they are followed in your unit and outside, and they have mandatory CT scan, I think. And because I don't know if a bullous emphysematous patient or a patient with obstructive but who has rather bronchial disease is the most responsive to non-invasive ventilation. I know that CT scan in a clinical trial are expensive, of course, but I think it could be useful to help to phenotype such patient. What is your opinion about that? I've used the data.
We don't do many CT scans on patients with COPD. There's reasons for that, because we just don't have the access to get the radiology. Yes, we can get as much radiology as anybody wants, but it's never been an idea that we would do HRCTs or cross-sectional imaging on our patients. And in fact, I find it really difficult, because when I do one on a patient, it always finds a nodule, and I never know what to do with that. And you've got someone who's really severe. So that's from clinical practice. Now, you'll be pleased to know that Dr. Patou, sitting in the front row, who we've stolen from you for the last couple of years, and unfortunately is going to be going back in the autumn, we're looking at the data that we published in Thorax last year, which is the 120 cohort exacerbation study where we're looking at neural drive to understand more about these patients. You're quite right. You've got emphysema at one end, you've got chronic bronchitis at the other, and you've got this group in the middle. And I don't think we do know who is going to benefit. We all know the patients we put on NIV, and their oxygen falls and their carbon dioxide goes up, and we're doing something bad to VQ during those patients. And I think we do need to understand more about the structure. And I think the data from Belgium helps us with that, with their specialist scanning, but also the data that Dr. Patou's putting together using EIT to look at ventilation and perfusion in a non-invasive way to understand the responders and non-responders to NIV. So like always, there's a bit more work to do.
Okay, thank you.
The question was for Nick and Patrick. We heard that pulmonary rehabilitation is really a standard procedure post-exacerbation. And we heard that also NIV and pulmonary rehabilitation are synergistic. So I wonder if in your study, the pulmonary rehabilitation component was similar on both arms, and did you adjust your results according with pulmonary rehabilitation?
We didn't prospectively insist on rehabilitation as part of the program, because those data from John Seymour were only just coming out, and that wasn't part of standard practice. So it's a very interesting point. The rates of pulmonary rehab, these were a very frail group, and so actually significant numbers of them. We're not fortunate enough in lots of European countries there's inpatient pulmonary rehab. In the UK, it's largely 2 visits to the hospital a week for supervised sessions, and these patients mostly were too frail to achieve that. So the numbers receiving pulmonary rehab within the first 3 months were actually very, very small.
Can I make a comment, obviously being one of the authors on the early pulmonary rehabilitation work? We excluded people with hypercapnia. We wanted it to work. So we did exclude those patients. I know obviously Peter's got data using NIV and rehabilitation, you have an improved effect. But we had a group of patients who really couldn't walk very far, and when we saw them, adding pulmonary rehabilitation to the burden, we were concerned about the burden of NIV. I think Doug McAvoy's trial from Australia, showing the AVCAL trial, showing this burden with a reduction in health-related quality of life, really weighed on us, because we knew we were putting ourselves out there in the fact that if we showed the fall in health-related quality of life, we were going to be in trouble, because obviously what we're going to go on to do next is cost-effective analysis. And you've got a relatively expensive treatment, and if you don't show an improvement in health-related quality of life, at least with our study in the beginning, then you're going to struggle for the healthcare funders to fund it, because it won't be cost-effective.
I mean, just on the further on the point, the objective exercise capacity of these patients is poor. I know from the rescue trial they didn't report the incremental shuttle walk test because it was so poor, and I haven't presented the data, but we did incremental shuttle walk test as opposed to 6-minute, and that had a mean value of 32 metres with over a third of patients having 0. And so, these were not patients able to get up and engage in rehab, or at least not at the start of therapy.
Do you have the wherewithal to do a cost analysis on this? I mean, because one admission saved for every 6 people put on NIV, I mean, does that cost out positively or negatively, or do you know?
We don't know yet. The data is being run through for a cost-effective analysis. That was in a priori plan, and we collected on the EQ5D as well to look at cost utility.
So that'll be forthcoming.
Yeah. So that's really important to highlight, but also, David, although death is expensive because it's costed by the health economist, readmission is far more expensive, and this trial prevented readmissions. So I think it's going to be, I don't think it's going to be difficult for us with holding or an improvement in health-related quality of life at the beginning, and then a maintenance of health-related quality of life in a group that didn't get readmitted. I think that's where the driver for the cost effectiveness will come. So we will have that data. We'll be swimming in this data like everybody is after a randomised control trial for years.
You've talked about exercise in this group. A study that we're in the process of writing up looked at exercise on NIV in the home, because we couldn't get our patients into rehab. It would have been a complete joke in the UK. But you mentioned, I think, Nick, the burden upon these patients. As a quantitative scientist, one of the most interesting parts of the project that my colleague has done is actually the qualitative data. So she's actually gone in and asked the fundamental question, with all the health quality of life questionnaires that these poor patients filled out. I think the key thing that we need to get a handle on is actually, what does the patient think? And I think that it would be really useful to get some good qualitative data from the patients as to how this wonderful study is going to translate into what the patients think.
I think that's a very good point. The one message we can say is those patients in the NIV group use their NIV more and more over the time. And I think, to me, that gives a strong message. If something isn't working, patients will vote with their feet and they will not use it. And these patients went from using it 4 hours to using it 7 hours, and they were perceiving an increasing benefit as they tolerated it more. And there's a proportion of patients who didn't tolerate it from the outset. They didn't tolerate acute NIV, and largely they didn't get into the study. So some patients will find it difficult, but I think those are the patients who won't start. Those who get in.
But that would only come out by actually asking the patients for their views as to why they liked it or didn't like it.
Yeah.
So all part of doing, you've done a randomised phase 3 trial. The next part will do the health service delivery. Embedded in the health service delivery, you can put semi-qualitative and qualitative research. It's time-consuming, it's difficult, it'll be an N = 10, but it will inform us where we're going in the future, because we want to not only find out where they tolerate the technology, but things we can do differently to ensure they continue using the technology.
Well, it's 7 p.m. On behalf of David and myself, on behalf of the sponsors Philips Respironics and ResMed, thank you to the Hot HMB team. Thank you, Nick and Patty, for doing a fantastic research job and really helping to get new care management models for these patients in place. Thank you, Michael, for an excellent speech. Thank you to you all for coming tonight at this late stage in this Mediterranean climate. And I hope you have a wonderful evening in London. Thank you very much.